Good morning. I'm Dr. Kim Reiss. I'm an assistant professor of medicine at UPenn and a medical oncologist focused in gastrointestinal cancers. And I would like to thank Dr. Domchek and the Basser Center for this opportunity to speak to you today on what I think is a very important topic, DNA damage repair in patients with pancreatic cancer. This model represents the standard of care for most patients with metastatic pancreatic cancers. Patients that we see with incurable disease are treated with perpetual chemotherapy until either progression, severe toxicity, or clinical decline or death. The model is based on the fact that about 10 years ago, our survival for metastatic pancreatic cancer was about 3 months. And so our focus was completely driven by trying to expand the lives of our patients who were dying so quickly. But since 2011, several combinations of therapies have emerged and are now the standard of care for this disease. And our median survival is just over a year. And within these patients, there is a specific subset that appears to do far better than the rest. These patients have durably responsive disease on chemotherapy with really sustained responses, sometimes months and sometimes even years. And so that is that's an extraordinary shift in the face of such a lethal disease. But perpetual chemotherapy is not a reasonable strategy for patient care. It is cumulatively toxic, it degrades quality of life, it leads to organ dysfunction, and ultimately it also fuels therapeutic resistance. And this compels us to consider an alternative model for these patients, and more importantly, to figure out what is different about this group so that we can shape rational maintenance therapy approaches. This slide shows a schematic of that alternative model in which we would use chemotherapy as an induction treatment to both reduce disease burden, improve symptoms, and stabilize the patient. And in those who achieve some degree of durable response, offer lower toxicity maintenance therapies with a goal of maintaining tumor control and at the same time sparing the human from that cumulative toxicity. Our hypothesis would be that there are subsets of patients with pancreatic cancer who have a durable response to cytotoxic chemotherapy and are biologically unique, and that this biology might be exploited to help us develop effective maintenance therapy options. This is probably the most compelling argument to develop maintenance therapy for pancreatic cancer. Every red line that you see on this geomap is a patient with advanced incurable pancreatic cancer and a pathogenic variant in BRCA or PALB2. These patients at the time where they were living in these various cities and countries were on active chemotherapy that was controlling their disease. Instead of choosing to continue that treatment, each of these patients decided to stop chemotherapy and instead travel every month to Philadelphia to participate in an experimental maintenance trial of the PARP inhibitor rucaparib. I don't think you can more poignantly illustrate the desperate need for maintenance therapy in this disease. So who can we effectively target for maintenance? Patients with BRCA variants represent the first unique biological group for whom successful maintenance therapy was and is being developed. 5 to 8% of patients with pancreatic cancer have a pathogenic variant in BRCA or PALB2. And recently, in the last couple of years, germline and somatic testing have become standard practice for the care of patients. So we can now readily identify this group and try to target them. They are, much like other BRCA-related cancers, highly sensitive to platinum-based chemotherapy and also to PARP inhibitors that, as you will know, are much less toxic than traditional cytotoxic chemo. So it makes a lot of biological and clinical sense to try PARP inhibitors as the first maintenance treatment in this group. The Polo trial, which was published in the New England Journal of Medicine in 2019, examined this strategy in an international phase 3 randomized study. The trial randomized patients with germline pathogenic variants in BRCA1 or 2 and metastatic pancreatic adenocarcinoma to get either Olaprib or placebo in a 2-to-1 randomized fashion following at least 4 months of platinum-based treatment without evidence of progressive disease. The trial demonstrated a doubling, you can see this on the left, of progression-free survival between the groups with a hazard ratio of 0.54, which for context is an extremely rare event in a pancreatic cancer trial. The final survival analysis, which you see the preliminary analysis there on the right, the final was presented at ASCO GI this year, showed no difference in overall survival between the groups, with a survival of 19.2 months versus 19 months in the placebo group. Just to note though, the trial was not powered to detect a survival difference. What is striking though, and what I want to draw your attention to about the PFS curve, is the apparent wide degree of biological variability in the success of treatment. So you can see on the left side of the curve, nearly 25% of patients, even with germline BRCA 1 and 2 variants and platinum sensitive disease, about 25% had progressive disease within 8 weeks of starting PARP inhibitor therapy. On the other end of the spectrum, 23% of patients on the study had a resist response to PARP treatment, and they had a median duration of response of about 24 months. So there is huge biological difference between people who immediately progress and clearly do not respond to PARP inhibition and those who respond extraordinarily well, and this goes on sometimes for years. So what does that mean? So what it means is that genomic panel testing is an insufficient biomarker to predict response to DDR-based therapies in this disease, and that the improvement in therapeutic outcomes will rely on more precise identification of patients and understanding who is who. The Polo trial maybe is partially practice changing, but more importantly, it should probably drive us to further refine our ability to find the right patients for DDR maintenance strategies. And there are several big questions that require answers. For example, are there other genes beyond germline BRCA variants that might lead to similar responses to PARP inhibitor therapy? Are there tighter or different clinical criteria that could be used to select patients more appropriately? And finally, we need a better biological understanding and categorization of patients so that we can identify the right groups without limiting ourselves solely to genomic panel testing as the benchmark for patient selection. This slide shows the schema for a second, slightly different maintenance trial that is currently ongoing at UPenn. We presented an interim analysis of this trial at AACR in 2019, and the final manuscript is currently in press at the Journal of Clinical Oncology. In this single-arm phase 2 trial, which was highlighted by the geomap that I showed you earlier, these are the patients who joined this trial. We tested maintenance rucaparib in patients with platinum-sensitive advanced pancreatic cancer and pathogenic germline or somatic variants in BRCA or PALB2. Much like Polo, patients were taken off chemotherapy after a successful period of induction and were given rucaparib monotherapy until disease progression or until unacceptable toxicity. Our primary endpoint was PFS. With this design, we attempt to expand the possible group for which PARP inhibition may be relevant. We allowed, first of all, for somatic alterations as well as germline alterations. We allowed patients with PALB2, and we allowed different histologies other than adenocarcinoma. We actually had a patient with squamous cell carcinoma and a patient with acinar carcinoma. So what we're trying to do there is build on Polo by expanding our group and seeing if we can successfully do so. Another critical difference between the two trials was actually the specific inclusion criteria in regards to platinum sensitivity. Although it's an imperfect correlation, it's generally observed, and this is backed up by good science, that resistance to platinum therapy is correlated with resistance to PARP inhibition. So in Polo, patients were excluded who had tumor progression by resist to platinum therapy. But as this table shows, that gives you a fair amount of leeway. So it only excludes people who had at more than 20%, equal or more than 20% growth in existing tumors from their prior scan or new lesions. Our protocol was a little bit different. We excluded patients with any clinical evidence of resistance to platinum therapy, and that included any growth in existing lesions or even a steadily rising tumor marker, CA19-9. And either of those things might indicate early platinum failure. Although that's maybe a seemingly subtle difference, being extremely biologically selective about who goes on maintenance PARP inhibition therapy might translate into differences in observed drug efficacy. I can't show you the final data from the paper because that's currently embargoed, but this slide shows our interim analysis, which we presented at AACR in 2019. The Kaplan-Meier curves and the waterfall plot of the first 19 patients are there, and I just want to point out a few things. First, we did observe partial responses in patients with PALB2 mutations, PALB2 variants, one of whom had squamous cell carcinoma of the pancreas and not adenocarcinoma, as well as in a patient with a somatic BRCA pathogenic variant. This indicates possible expansion beyond a maintenance option solely for patients with germline BRCA variants. Second, this is a very small group of patients, but we observed an overall response rate of 41% compared to 23% on Polo, and a PFS of 9 months compared to the PFS of 7.8 months seen on the larger Polo study. This, of course, is extremely hypothesis generating and in no way conclusive, but you do wonder if perhaps one of the variables that might have led to that difference was our stricter criteria for platinum sensitivity. We're currently in the process of doing genomic analyses from patient samples to kind of expand our knowledge about sensitivity and resistance mechanisms in this particular group of patients. So now let's shift gears a little bit and talk about trying to identify patients with a DDR deficiency beyond panel testing. We have recently learned that in pancreatic cancer, PV, pathogenic variant, doesn't always equal HRD. This reminded me of PV equals NRT from physics when I was in high school, but it is, I think, very true. This is a very important new finding in the field of pancreatic cancer, that these things partially overlap, but actually are not always the same. Talia Golan and Steve Gallinger, from whom this figure is drawn from their paper, they recently published a really landmark study where they looked at 416 pancreatic cancer samples and looked for signs of DNA damage repair deficiency by a couple of different assays. They used HR Detect, they used Signature 3, they used the Myriad MyChoice assay, and they used genomic instability score. They found that of all these, HR Detect was the most specific and sensitive for assessing a DDR deficiency. The downside, of course, is that this assay is done, is whole genome and is done from fresh frozen tissue. And so from a clinical standpoint, it's somewhat impractical, but it is a very important finding that this correlates with DDR deficiency. And they made some very critical observations that need to be built on both preclinically and clinically. And this figure, although it's very big and very busy, just a couple of things to point out. First, some of the patients with sporadic pancreatic cancer had HRD high tumors by HR Detect, which is shown by the darkened squares there. So if you look at the dark square compared to the gray square compared to the white squares in the top row here, this one is a sporadic cancer. This one is a sporadic cancer, both that were HRD high. Conversely, some patients with pathogenic BRCA mutations did not have an HRD high tumor. In fact, they had an HR proficient tumor, and here is the white square there. This figure only shows a very small sample of all their data. Obviously, it's not the whole 416 samples, but overall, what they found is that about 12% of patients with a known BRCA pathogenic variant were HRD proficient. It's about 1 in 10 patients we see in the clinic potentially, and that of the sporadic cancers, 7 to 10% of them were HRD deficient, which is a really important finding. And it highlights for us that the identification of a pathogenic variant is an insufficient biomarker, and what we really need is ways to identify these patients better in a way that is clinically usable. Our system is currently incomplete, and we need to explore further. In 2017, we launched the more exploratory single institution maintenance trial called PartVAX at UPenn. And the goal behind this trial was to evaluate the efficacy of a maintenance DDR-directed therapy in a broader population of patients that were defined by a phenotype of durable platinum sensitivity rather than by a genotype. The trial had non-comparative primary endpoints, PFS, and will complete enrollment this summer with just a few slots left on the trial from the original 84 slots we started with. And the truth is that platinum sensitivity is probably too broad a biomarker for capturing DDR patients. And so the most critical piece of this study are the genomic and immunological analyses of patient samples, and to correlate those then with clinical outcomes and other clinical features like tumor burden, for example. And the goal will be to identify more reliable and clinically usable biomarkers that will inform the next study so we can refine the group further. In collaboration with several different laboratories at Penn, patients on this trial undergo deep genomic and immunological characterization, which is aimed entirely at the confirmation and discovery of specific signals that might predict for success of an HRD-driven maintenance strategy. Just to highlight a few of those things, Dr. Nathanson's genomics laboratory will be performing germline sequencing, whole exome germline sequencing, and also DNA and RNA extraction and analysis of tumors to look for DDR-specific signatures. Dr. Gregory Beatty's laboratory, which is focused, his laboratory is a discovery laboratory focused on the immunology of cancers, and specifically pancreatic cancer, will look at immunological characterization of tumor microenvironment at baseline, and then also shortly after the introduction of therapy, so after cycle 2. And they will use multiplex IHC and will look at PBMCs via CyTOF. And he also plans to perform RAD51 foci staining on tumor samples to look at, for a functional DDR deficiency. Erica Carpenter's laboratory will collect serial samples of cell-free DNA that we can then use to evaluate specific mechanisms of response and resistance, and those will be analyzed in potentially analyzed in partnership with industry. And Dr. Ben Stanger's lab is generating organoids from samples that are collected from patients on trial, and which then can be used for deeper genomic characterization and also for drug testing in a mouse model. And these are some of our organoids from the initial patient organoids that we developed from patients on this trial. Clinically, from the clinical side, features like disease burden at study start and specific responses to the prior platinum therapy that patients received, and family history of patients who go on study will all be captured and then evaluated against PFS. Here's a quick example of somebody who is on this trial, and it's an example of what we might miss when we rely solely on genomic panel testing to capture patients. This patient has been on the PartVAX trial for 3 years. In June, it will be 3 years. She was diagnosed with metastatic pancreatic cancer in 2017. She received FOLFIRINOX and then FOLFIRI as a maintenance chemotherapy as part of her clinical care. And her tumor was extremely sensitive to this strategy. Her liver lesions disappeared, but her primary pancreatic tumor was still there. And she underwent, as you can see there, germline in vitro panel testing, very typical, and that was completely negative. She enrolled on the PartVAC study in June of 2018. Her pancreatic tumor now, 3 years later, is no longer visible, and she remains on study to this day. And at this moment, we have no obvious marker, such as a genomic variant, which we would rely on to explain her prolonged response to treatment. And there are other patients on the trial that are equally enigmatic in this way. And these are the critical people. These are the patients we need to understand more deeply, and we hopefully will, using the multi-pronged approach that I described. And if we can figure out why these patients do so well, then we have the opportunity to use those biomarkers prospectively in the next trial that we design. For the last part of the lecture, I wanted to briefly switch gears again and focus on targeted therapy with curative intent. You may know that 10 to 15% of patients with pancreatic cancer have resectable disease at their diagnosis, and this number is slightly higher if we include patients who have locally advanced disease, who undergo neoadjuvant therapy and eventually make it to surgical resection if they have a very good response to neoadjuvant treatment. Treatment before and or after surgery, we do a perioperative approach these days. It consists of an intensive triplet regimen called FOLFIRINOX, which this is based on the PRODIGE study published in 2018. The 6 months of FOLFIRINOX is now the standard of care around a pancreatic cancer surgery with curative intent. And even with that standard of care approach and that intensive regimen, over 50% of our patients will still recur. The Olympia trial, which was recently reported as positive, and looking forward to that at ASCO, those details, confirmed a benefit of Olaprib in patients with BRCA-related breast cancer who completed all standard therapy for curative intent standard therapy for early stage breast cancer. And we will aim to do the same for patients with BRCA or PALB2 related pancreatic cancer. So this is the trial. This activated on the 29th of April. So really fresh. It is a randomized double-blind study, very similar. I think of it as Olympia for pancreas, a double-blind study looking at the benefit of 1 year of Olaprib versus placebo after completion of all standard therapy for early stage resected pancreatic cancer and a germline or somatic BRCA or PALB2 mutation. This study is an ECOG-ACRIN effort along with SWOG and Alliance, but ECOG-ACRIN is the leading cooperative group and will open at possibly 600 centers, and it will also open in Israel. And one of the critical advantages of this study compared to some of our work in advanced cancer is having the samples of resected tumors. Pancreas cancer is very hypocellular. And so sometimes even if you get a biopsy, you don't get a lot of tissue. But since we will be collecting the resected tumors from all patients, as well as, of course, cell-free DNA at particular time points, study start, treatment end, and recurrence, we hope that we will be able to do a deeper dive into what the biology is of this particular subgroup of patients, including genomics and proteomics, et cetera. In conclusion, my parting thoughts here are that a meaningful subset of patients with pancreatic cancer have a DNA damage repair deficiency. And in fact, it might make up to 15%, maybe a little bit more of the patients that we see in our clinic if we can identify them. We need to therefore develop clinically usable assays to show a functional DDR deficiency as a way to identify patients rather than genomic panel sequencing alone. It gets us very far, but it doesn't get us all the way there. And if we can optimize our identification of these patients, we can better learn to strategize therapies for them, including maintenance treatments and also curative intent therapy. This is obviously a hugely collaborative effort, and I want to just give my sincerest thanks to my extraordinary Penn Medicine colleagues and mentors, with a special shout out to the research team here who make sure that the patients get such good care. And the work would, of course, not be possible without the funding of our grants, our foundation support, our industry partners, with a special note of thanks to the Basser Young Leadership Council, the Kohner family, and the Pearl and Philip Basser Award for their generous support. Thank you so much.